Welcome to the campus of North Idaho College and today's broadcast of the North Idaho College Public Forum. The crew is comprised of North Idaho College television students. Your moderator is North Idaho College political scientist Tony Stewart.
Today we wish to start a two-part series on a most important topic to all of you, and that is the question of death and dying. In order to do this over a two-week period, we would like to address ourselves to questions such as the care of the terminally ill, legal and ethical and medical questions that arise during the treatment of patients, and death and the whole issue. In doing this, we propose to break the program into two parts. This week we would like to concentrate on such issues as defining death. They are both legal, medical, and theological definitions. We would also like to discuss that awesome decision if someone appears to be terminally ill, and if we use life supports and so forth, who makes those decisions. Next week we will attempt to deal more with care for the terminally ill and stages that one goes through when one discovers that they are terminally ill. We will also discuss some other relevant issues to these questions. In order to accomplish this, we're very fortunate to have with us for a two-week period Dr. Jane Rabl. She has a baccalaureate degree from Tufts University in the field of sociology, and then she did graduate work at some institutions and received her doctorate in theology from San Francisco Theological Seminary. But she has also done additional postgraduate work at Harvard and other schools in the field of bioethics. She tours the United States and speaks on this subject and also does workshops. Dr. Rabl, thank you for being with us.
It's a pleasure to be here.
Joining with me and questioning our guest will be two regular panelists, and I'm happy to welcome a visiting member. Regular panelist Lou Reed, visiting with us Mary Jean Young from the nursing faculty at North Idaho College, and regular panelist Janelle. We'll proceed to questions at once from Mary Lou Reed.
Dr. Rabl, before we get into the question of defining death, there's another term that I'd like to have you explore a little bit, and that's the term bioethics. As I understand it, this refers to issues of birth, life, and death. I think it would be helpful if we knew a little bit more about the term and who's working in elucidating these issues.
Okay. It's a very complex and new field, and if you went to a library, you probably wouldn't find a catalog area under bioethics because it is so new. It's the whole aspect of a combination of healthcare technologies, which are changing rapidly, and the intersection of those concerns, what's happening in healthcare. How does it affect individual people as individual units and family units, but also how does it affect us as a country? What is our public policy concerns? And in all those questions are ethical implications. Most of the issues that I would call bioethical have then a healthcare aspect of it, what's happening in the hospital situation, what's happening societally, how does that issue affect us societally, but also what values come into play when we talk about a specific area. And of course the most popular area, I think the one we talk about most of all, happens to be the area of death and dying. When we think of bioethics, we think of the death and dying area. When we think of a classic bioethical problem, we think of the Quinlan case.
That was what I was going to ask, is if you could give an example, a typical example of a bioethical question, and you would say that that is sort of the quintessential one.
That's the one most people think of. There are many others that are of equal importance, maybe even larger importance, because they affect so many large numbers of people. For example, how do you do genetic counseling? Who do you screen and for what reasons? Who will pay for the screening process in genetics? It is an ethical question. It's a bioethical issue, and one of great concern in the Inland Empire is because you have a very fine genetics clinic that's concerned with the ethical implications of genetic screening and counseling too. That would be a bioethical area.
Quickly, are there any particular philosophers or people who are trying to get this down on paper and define it in a fairly clear way? Are there any outstanding minds at work, or all of you working at it together?
No, I wouldn't say that. It's such a new field, and people who are in the field are multidisciplinary like myself. There are very few people who are trained from the beginning to be bioethicists. There are physicians who work independently who have taken law and medicine and ethics on the side, and there are philosophers and theologians who have doing a lot of work in healthcare. There are nurses, there are people in medical records who are concerned about privacy aspects, people in public policy who decide they need to know more about medicine. So it's a mixture of people, and many of them are in touch with each other. Many of them are laboring alone in their own schools and hospitals and practices by themselves.
Thank you.
Before we move on, I think it's very essential from what Lou has asked that we attempt for our audience to define the debates going on about death. From what I read, there is a legal definition, theological and medical, concerning brain death or the heartbeat or respiratory system. Would you do two things? One, explain that controversy or those definitions, and if you don't mind, would you indicate to us what you think is the most reasonable to use in attempting to deal with these cases that we'll be talking about later?
All right. Well, the debate hinges around the fact that the classic definition of death is not always applicable. The classic definition of death is cessation of the circulatory system. No person is no longer breathing. Remember stories of holding a mirror up to the lips or a feather to see whether the person is breathing. The heart stops, and therefore the patient is dead. With our really amazing and wonderful technologies, we have come to a place where we can keep those different body systems functioning, but we're not sure whether the patient really is alive or dead. And one of the ways, the criteria that has developed over the years, is to use the functioning of the brain as a way of determining whether the patient is truly alive or whether we have a bunch of different pieces of machinery that are keeping pieces of the person alive. The general standard of practice, that is what is being done in most hospitals across the United States and Canada, is first to use the traditional vital signs. But when a person is kept, for example, on a respirator, which is the thing we think of the most, then we use, in most hospitals in Canada and the United States, we try to decide whether the person's brain is alive or dead. We tend to think of that as a flat EEG, that the brain registers nothing. In fact, that's not really quite the case. It's a lot more complex and sophisticated than that. And there are actually about 6 or 7 brain death definitions that are floating about. What's important is that we simply acknowledge the fact that there are times when the traditional definition doesn't work anymore. The Quinlan case is one such case again, but there are many such cases where I could walk out of the street right after the show, get hit by a car, register a flat EEG, and have experienced brain death, but enough other interventions are being used for keeping some of my bodily functions going. The question is, am I alive or dead? And clinically, the practice is to usually declare the person dead if there's a flat EEG. The problem is that while that is the case clinically, we do it in most hospital situations. In fact, many of our states and many of the provinces of Canada do not have a legal form of brain death on their as a statute. So it's being used, for example, in Washington State all the time in hospitals where it applies. It is, in fact, still technically illegal. What do I think about it? I think that, obviously, I think it's extremely unwise to be operating on the basis of a brain death definition without a legal statute to back you. And so I would say that traditional life signs should be used wherever those are appropriate, and then when brain death definition is appropriate, that should be used, but hopefully with a backup of a statute. It's a lot more complex than simply brain death. In fact, I think that Quinlan case, she has experienced brain death, but she still has neocortical function, and that's why she's able to continue even though she's been removed from the respirator. A little complicated.
Thank you. Mary Jean Young.
I guess you were talking about sophisticated support measures, and maybe this is jumping a little bit ahead, but as we have developed most sophisticated techniques for taking care of patients, do you think that what we considered extraordinary, say 20 years ago or 15 years ago, is now considered ordinary care of a person, and that in 20 years what we consider exceptional care or extraordinary will be considered ordinary?
I think that's true, very much true. I think that what was considered extraordinary or heroic or unusual such as antibiotics, the use of antibiotics. It wasn't all that long ago. That was extraordinary, and anybody who got it was a research subject. It isn't that far in our history. Now, not to give antibiotics into certain situations, a physician would be deemed negligent, and failing to bring aid would be liable to do that. So I think the same is true in the future, that what we think of as extraordinary now will be ordinary. The best example in the Northwest, I think, is the dialysis issue, the kidney machine. Kidney machine, this is our local history, which has had an impact all over the world, but the kidney machine was extraordinary in the 1960s, and we had to have a committee to decide who could have the kidney machine because there were so few of them. And now we as taxpayers in the United States pay for kidney machines for everybody. It's considered ordinary. It's also true, I think, that something that's considered extraordinary in Spokane would be considered, something that would be considered ordinary care in Spokane and one of the major hospitals there in Seattle will seem extraordinary in a small community hospital. In other words, there are specialists in some of the major hospitals that can provide a certain kind of care routinely that are impossible to provide in small towns in the provinces and states of our countries.
Janelle Berg.
You have been speaking about hospitals. Can you please talk about the goals of major hospitals in urban areas and how they affect the patient, and particularly the patient who is terminally ill?
Oh, this is one of my favorite questions because I think it's a fascinating one. I think most patients who go to hospitals and most members of the family assume that when they go to a teaching or major city hospital that they're going for patient care, that is the primary function of the hospital. In fact, the primary function of the major city hospital is threefold. One is patient care, a second is teaching, and a third is research. Each one of those are extremely legitimate. Beyond that, they're all necessary, but beyond that there's a fourth function, and that is something that we as citizens demand in both our countries, and that is fiscal responsibility and therefore a good sound administration. So we're talking about four different categories of goals. And what's confusing is that when we get a very difficult, complex patient problem, we're not simply talking about the management or care of a specific patient, but that patient may be inextricably caught up in the teaching mechanism of the hospital, and if there are an interesting case or has a problem that is subject for research in that particular setting, may also be a research subject. And I think it's very hard to keep those different goals separate. And it's interesting that in nursing services, wherever I go on both sides of the border, nurses will say emphatically that the first goal of the hospital should be, not is, but should be patient care. And yet there's been a very interesting study done in some of the major hospitals in this country, showing that if you are teaching in a medical school with an adjacent hospital, like University Hospital in Seattle, for example, the first goal, as you would see it, would be teaching. The second goal would be research, and the third goal would be patient care. And if you were teaching in the biological sciences in the medical school, you would feel that patient care wouldn't even be on the list. I mean, this is the study that was done. That shows why we have such complicated problems when we start thinking about how are we going to treat patients. We're all, those of us in the decision-making arena, the physicians, the students, that is the house staff, the nurses, the family, the patient, all have different expectations about why that patient's there and what the purpose of the hospital is.
In a day like today, when we want to take advantage of all the specialties, but we still want to assure ourselves of total patient care, how can we do this? What is the best approach to make sure that the total system is being looked at and not just each individual specialty one at a time?
Well, you're going to get a very strong personal bias at two levels. One is that I think that the consumer, as always, must beware. It needs to be as completely in control of the decision-making process and the choices, and recognize that not every healthcare setting is going to meet her or his needs. I mean, that is an individual decision. Not every physician is suited to every single patient. And that we each have some control over that. And the time to make the decisions about whether I've got the right physician or the right hospital is not when I'm critically ill, but in advance of that situation. So if there's some areas in which I feel strongly about how I'm going to be cared for when I'm dying. I have been very careful to raise that subject with the people who are most likely to care for me, my family and my healthcare team. And I have changed physicians recently because of that. Now I'm more assured of that. The other area is that that one also needs to be sure that in the situation when one can't make decisions for oneself. I mean, I was in a situation a few years ago where I was heavily medicated. I then appointed other people whom I could trust to make decisions for me. It wasn't a legal thing, although I did sign their names on the consent form, but I protected myself that way. The system is so huge, it's impossible for anybody in it to keep control over it, but that's at least a way of managing. I think also your choice of specialty may be important to you. For me, family medicine has been an important choice because family physicians tend to see themselves as manipulators of the system in behalf of a holistic approach to the patient.
Ladies and gentlemen, if you've joined our program in progress, our guest is Dr. Jane Rabl. She holds a doctorate in theology from San Francisco Theological Seminary in the field of theology, medicine, and bioethics. We shall continue the questioning with Lou Reed.
Dr. Rabl, would you talk a little bit more about the rights of the terminally ill to choose to die? Perhaps you can bring us up to date on some of the legislation in the different states that permits this. I think California perhaps has a little bit more liberal act. Please elaborate.
Yes, I will. Thank you, because it's, again, another area that I like to discuss. The patient wants a majority age, and as long as the patient is legally competent in the United States, the situation is slightly different in Canada, so I need to be specific to the United States. But as long as the patient is legally competent and over age, majority age, the patient always retains the right to make decisions in his or her behalf. That includes the right to refuse treatment when dying. The problem is, that's guaranteed by our Constitution. That's what we mean when we talk about the right to self-determination in this country of all our citizens and the right to privacy. And the courts have seemed to interpret that as also to mean the right to refuse treatment. The problem is with the dying patient, as most of us know from our own experience, whether we are healthcare professionals, whether we have lived through the long dying process, somebody in our family, our parents or a spouse or a friend, we know that in fact what happens is that we get very frightened in the situation if we're family members. If we're the dying patient, we're debilitated. We can't walk out of the hospital. If other people want to keep us there, it's very hard to get yourself out of the situation. And so many people have been concerned that they have the opportunity to write down their beliefs in advance of their dying, and to know that those wishes that they be allowed to die naturally when nothing else can be done really to help them, that all that's being done is prolonging their dying process unnaturally with needless interventions, that then I be allowed to die. And many people are concerned that there be some vehicle by which we could say legally, this is what I want. You won't be liable as a physician or as family if you turn off the respirator or whatever it is. This is what I want you to do if I'm dying. And so California was the first state in this country to pass a really rather imperfect law. Washington State and Idaho both have natural death acts. They're very different from one another. But they do allow people to, under very certain circumstances, to sign a statement in advance saying that under these circumstances I wish to have all interventions ceased. And the reason for this is that many people fear that they will be too frightened to do anything about it. Their families may not concur, or more probably they will not be in a physical condition. They may be comatose,
drugged,
heavily drugged, many different things, and not be able to say then what it is they want.
But you feel that the California Act is not perfect.
I think it's a pretty poor act.
Yeah, what are the elements that you need to make a really excellent Natural Death Act?
Well, the problems with the Natural Death Act is that it requires signing 14 days in advance of execution, which means that if you're badly burned and you're going to die anyway, say 95% burns over your body, that they can't allow you to die, let you just die naturally. They're going to have to continue to intervene for 14 days. And that's crazy, really. We don't do that with bedside wills. It requires, as does in Idaho, to be renewed every 5 years. Washington State does not have that provision. Well, if you're like me, I can't remember when my driver's license is due, let alone what
How you want to die.
it's impossible. And if you think of yourself being in a long-term illness situation, such as an extended care facility or a nursing home, it's really unlikely that you're going to be able to remember that 5 years later you're going to need to reissue it. Another problem with both California and Idaho, which is not true in Washington, is that it's only legally binding if you sign it when you've been diagnosed as terminally ill. That is, I could sign the statement, have it properly witnessed, but if I have not been diagnosed as terminally ill, in Idaho that would require a statement by one physician, in Washington State by 2 physicians. Here in this state, it would mean it would not be legally binding. It would only be an advisory thing. But if I were diagnosed as terminally ill in Idaho and then signed it would be legally binding. In Washington State, as it's getting too complex, in Washington State, I could sign it whether I'm healthy or I'm dying, and as long as it was properly executed, it would be considered my firm wishes. In all states, they're easily revocable, so you can change your mind. This isn't something you sign and it goes on forever.
I think there's a follow-up question that I would like to ask. Lou was breaking the ground that I was thinking about. You've talked about the right to make the decision about whether or not you want certain extraordinary means used in your case, and you've talked about the competent person to make decisions and the incompetent. There's a gray area in between. I would like for you to define a little more in depth from examples of people that would fall in these 3 areas, and you've given today some interesting case studies so that our viewers may see how one might be able to make a decision themselves, or why it maybe have to be made with the courts or the family.
Okay. Obviously, a competent person is a person whose brain is functioning and is able to know what's going on and can exercise informed consent. Can understand what's happening, and it can freely give consent for something or refuse treatment. Unfortunately, many people get into our healthcare system who are lucid and competent to make decisions on their own behalf, but for one reason or another are denied the right to do that. I think, for example, of an older woman I know who was dying for many, many years. Took a very long time for her to die in a nursing home, and she was under restraints all the time. She was a very, very tiny person and had no family left. And every time I went to see her, she said to me very quietly, "I want to die." But it was very clear. I mean, there could be no mistaking what she was saying. And I wondered about her because in some nursing homes and hospitals, if she got pneumonia, it would be, or she went into cardiac arrest, more probably. In some situations, she would be subjected to all the intensive intervention that we can bring in order to restore her body function, although she'd been very clear about the fact that she was dying, and in fact dying at this point was a friend to her. Now there is a person who was competent and very clear about what she wanted, but I suspect her needs would be overlooked at the time because she had no advocate, no family there to back her up. In the gray area is much more what I call the gray area is much more complex. It's an area in which the person is perfectly competent, and the mind is in good order, but because of the kind of injury the person has sustained, or because the person is in a coma and then is lucid and then goes into the coma again and then is lucid again, or because a patient has chosen not to take an intervention that the physician thinks is important, is considered incompetent. Let me give you an example. This happens very often in the situation where a patient is offered a kind of treatment, a dying patient is given a kind of treatment option, and says, "I really would rather not. Thank you very much. I had a good, rich, full life. I would like to be allowed to die gracefully." The example which comes closest to mind is a grandmother I know of, and was written up, well publicized in the United States, who suffered multiple amputations and then finally said to her physician, "Enough. I've had enough. I don't want any more." He indicated this would go on for quite a while. And her 3 sons said she was incompetent to make up her own mind and wanted to have them continue surgery. Now, she was competent. They went to court. The judge said, "This woman is of age, she's of sound mind, she's not incompetent just because she doesn't choose the intervention the physician wants and the sons want. she's free to make her own decision. So that's one of those gray areas where you can be treated as if you're incompetent because you're dying, or because you won't choose an option that other people think is good for you, or because you're badly hurt and people think you may not think straight. Then there are, of course, the classic cases like the Karen Quinlan case, and there are many of them, where people truly are not competent, either because they're profoundly retarded, they are very small children, they are comatose, or they have suffered brain death. And in those instances, the way we handle it is if the patient can't speak for himself in this instance and has left no living will or natural death act, that if the family and physician agree on the proper recourse, whether to withdraw means or supports like the respirator, whatever, then that's done. If there's disagreement among the medical staff and or the family, then it usually goes to the courts for the courts to decide. And that may not be the best system, but at least that's the best system we have in the United States. It's a little different in Canada.
Mary Jean Young.
You've been talking about hospitals, and we started out with rural hospitals and then went into metropolitan and teaching hospitals. I was wondering if you were familiar with the growing program of hospices.
Oh, yes.
And what your opinion were of whether this was a more humane way to approach the subject of dying.
Well, of course, I think it is a far more humane way, just because there comes a time when people need support and nurture, and that is the kind of care they need. The kind of care they don't need is further interventions. And
We'll need to explain to the viewers what that is.
That's of course true. Hospice is a new, I can't even say building, it's a new methodology, way of treating the dying patient, and that is treating them openly, kindly, not intervening any longer with all kinds of interventions, both surgical or chemical, but instead trying to keep the patient as comfortable as possible, trying to meet that patient's needs to the fullest degree possible, and try to keep the patient in a non-hospital-like setting where the patient is living as fully as possible, even though dying. And of course, that's an extremely humane way to be. I mean, we remove our dying patients and put them away from us. We take away all their choices and options. We do not allow them to live even though they are still living among us. And hospice is an attempt to rectify that situation. And I heartily endorse it. I think the thing that we need to be careful of is that not everyone is going to want to be in a hospice. That it's becoming of great interest in both Canada and the United States, and our eagerness to make sure that we have good hospice programs such as the one in Spokane. Remember that there are people who are going to prefer to be in hospital situations, or people who are going to want to be home for one reason or another.
I must interrupt. I'm sorry we're out of time, but we'll be back next week and we'll discuss this. And Janelle, we'll pick up with you on round 2 for that. Ladies and gentlemen, I hope you've enjoyed our program and that you will be with us again when Dr. Jane Rabl next week will discuss with us the care of patients, and especially those who are in for long periods of time and are terminally ill. We also want to deal with the stages that a dying person oftentimes experiences, or this has been indicated by some writings that she will discuss. I hope you will be with us at that time. Have a good week. I am Tony Stewart.
The North Idaho College Public Forum can be seen at the same time each week over this station. This production was videotaped earlier by a North Idaho College student crew for viewing at this more appropriate time. Welcome to the campus of North Idaho College and today's broadcast of the North Idaho College Public Forum. The crew is comprised of North Idaho College television students. Your moderator is North Idaho College political scientist Tony Stewart.
Ladies and gentlemen, this week we want to continue our discussion from last week for you who are with us, and if you were not, we were discussing that very important issue of death and dying. We addressed ourselves particularly last week to defining legal definition in particular of death and who makes that decision concerning extraordinary care for the dying, or should not that be used. This week we wish to discuss care of the dying patient in a general way, and secondly, grieving dying processes, among other issues. In order to do this, we're happy to welcome back to our program Dr. Jane Rabl, who holds a bachelor's degree from Tufts University and a doctorate in theology from San Francisco Theological Seminary. She also has dealt heavily into the fields of medicine, bioethics, and theology. She has done postgraduate work at Harvard University. Dr. Rabl, welcome back to our program.
Thank you.
Joining me again this week in questioning our guests on this important subject is regular panelist Mary Lou Reed, visiting panel member and a member of the faculty at North Idaho College in the field of nursing, Mary Jean Young, and regular panelist Janelle Burke. We'll start the question this week with Janelle Burke.
When we discover that we are terminally ill or that a loved one is terminally ill, we can expect to experience certain feelings. Can you outline those for us and help us to deal with them?
Well, I'm not sure I can help you deal with them in 5 minutes, but I certainly can outline the feelings. Kubler-Ross first characterized what she called the stages of dying. I prefer to call them the awareness of dying. There are different levels of awareness that one goes through as one deals with any bad news. I mean, it's true of any difficult crisis in our lives. And the first one is denial, usually for most people. Simply an impossibility, this can't be me, not able to deal with it, not hearing it, not responding in any way. It's a sense of no, not me. The next stage or level of awareness is a beginning recognition that this terrible news, this terrible thing, I'm dying, is happening to me, and it results in anger. It is me, and why me? Just absolute rage, and this can be a very, very difficult time for the patient, but an extremely difficult time for staff and for family, because it can be a rage against the physician, it can be a rage against the family, they don't love me, they aren't taking care of me, it can be throwing trays on the floor, it can be all kinds of acting, and must be understood as a rage against this thing that is going to take my life. Kubler-Ross talks about a third level, which she calls bargaining. I tend not to think of bargaining as a separate stage, but rather another form of denial, which is simply, well, it might be me, but give me a little more time, and I think that's just another way of denying reality. Then after you've gone through the anger part, usually most people, after they've had a chance to think about whatever crisis they're going to, in this case, the dying process, usually become very depressed as they begin to think about the implications of this terrible news, which I first rejected and got angry about, how it's going to affect my life. Everybody else is going to go on, and I am not going to be here. This patient is probably the easiest patient in many ways to deal with, because the depressed patient is a very quiet patient usually. When you see a depressed child, a dying child in a hospital unit, they're very often sucking their thumb, holding their teddy, and staring at the TV. Or adult will be very, very quiet, withdrawn, very, very easy and placid, but they need a lot of intervention in the sense of not abandoning them in a physical sense, being there. And then finally, some people get to the point what Kubler-Ross calls acceptance. I think that's a misleading term, because I think that it suggests that most people think that it's a stage where I feel good about what's happening to me. And she didn't mean to say you feel good about it, and I certainly don't think you do. I think instead it's more often a feeling of, well, I wouldn't have asked for this to happen to me. I'm not ready. I wasn't ready to die, but now I've made my peace with what is happening. I recognize that the time has come, and I begin to let go. Now, some people, I do need to amplify just a little bit, and that is that some people don't go through any of those stages. Some people are stoics, I think. They just deal with what they have to deal with. And other people jump from the beginning and go to the end. And some people, one should not think of these stages as something everybody should go through.
there?
Sometimes people, as a part of the bargaining process, I would suppose, go from one place to another. Once they've discovered, they've been told they're terminally ill, they go to a number of medical facilities, or they go to a number of doctors. What is your response to that? And is it a healthy approach, or how can we make it less of a deterrent or less of a frightening experience every time it happens?
Well, I think it's true that some people will respond, many people, in fact, I think all people ought to respond that way in the sense, I'm not sure it's bargaining, but simply either a denial or saying, I'm going to get the best treatment I can. If it's I'm going to get the best treatment I can, then all the more power to that patient and that family who says, I'm not going to take the first thing that's offered to me and assume that that's it. But if it's a frantic running around trying to find one possible treatment option after another and not accepting going on, then I think, well, we might call it bargaining. I tend to think it's another form of denial, not willing to deal with the reality. And I think there's not much you can do about that. You're not going to force people out of one awareness into another. You're not going to force people out of denial or out of anger into another stage. I think not only is it impossible to do that to human beings, I think it's really unethical for us to think that we can dehumanize people in such a way that we can push them. We think that they ought to go from denial to anger to depression and then at last to the great stage of acceptance. I think people need to be where they need to be, and it's not our responsibility, especially when they're dying, to be unsupportive where they are.
Do I understand from what you have said that you favor talking about the subject, favor thinking about it, and reaching some kinds of at least having come to terms in some ways with each of these stages if you're going through them, or whatever your thought may be?
Well, I don't think it's a situation in which we have much choice, Janelle. I think what's important is that the people around the dying patient understand that there are various ways of responding to the fact that I'm dying, and be sensitive to the varying needs that each stage requires. And to remember that a person can deny in one sentence and be dealing with it in the next sentence. There's nothing wrong with the patient. They're just real. One nurse said to me, you can't look at the sun forever. And you cannot look at the fact that you're dying 24 hours a day. It doesn't mean that you're not healthy and not dealing with it. It just means that you can't deal with that kind of reality on a 24-hour basis. And I think families and staff need to be very, very sensitive and careful about projecting their needs on the patient or requiring that the patient behave in a certain way because that would be the best way to behave.
Lou Reed.
Do I understand that a grieving person goes through these same comparable stages? Is that correct, that you're talking about dying, grieving process in sort of the same terms?
I think I would certainly characterize that in my professional life, that yes, most people who go through any life crisis or share the life crisis of another, whether it's dying or it's divorce or the burning of a family home or the loss of a child or the loss of one's family income, yes, all of those things are forms of grieving because it has to do with one's identity and a change in oneself. And yes, I would say that most of us rush from the information. We deny it officially first, and then we get angry. Why was I singled out? Why did this happen to me? And eventually we get very depressed about it, and then finally we learn to live with it in some way.
How do we know when a grieving person may be pausing too long in one of these stages? What is normal and what is abnormal? Is it possible to say?
I would not make a categorical statement. I have heard people say that, if you are still denying after a year, if you're still grieving after a year, something's wrong with you. Well, I know perfectly healthy people who have had terrible horrors that they're dealing with 2 years later and 3 years later. I think it is instead watching that individual and the sense of movement within that individual. If they seem stuck forever, then there's some area of concern. I really have some concern about people when people start saying, it's 6 months, this person ought to be at this particular place. Part of the problem is that there's a difference between how we respond when a person dies suddenly and a person dies over a long period of time. When we've had a long, prolonged dying process, we've had a long time to get used to the fact that this person is no longer going to be with us. We've also had time to be angry about it and fearful about it and feel guilty about having those feelings. We've had a lot of time to begin to think about, however unpleasant it is, that we're going to live without that person. So for many people, the grieving process will occur before death. And then people around us say, well, why doesn't she cry? She doesn't act like she's very sad. In sudden death, it's quite the reverse. The person was sitting at the dinner table, walks out onto the street, and suddenly you have law enforcement officers telling you that this person is dead. The reality of that death, it takes weeks of sitting at that table and seeing that empty place before the reality of that death even begins to sink in.
How do family and friends really do, what are the best things they can do to help in either the dying or the grieving process in relationship to the patient or to the grieving person? You know, are there any kinds of tips that places where we are apt to be blind and say and do the wrong thing?
I think so, Lou, and I think it's superimposing our own needs on the other, making value judgments about what they ought to be doing. They really, you know, that they shouldn't be denying, or they shouldn't be angry, that they should be somewhere else. They ought to be crying. The big thing these days is now that everybody ought to be expressing their grief by crying. Well, some of us were raised not to cry. You know, I happen to be Mediterranean. It comes very easily with me, almost too easily. But some of us were not raised in that tradition. And I think it's a mistake to think that that person is not going through the grieving process appropriately, whatever appropriate means, if they don't express it in the way we wish to. We are a diverse people. We have different ways of responding to crisis, and we need to be very, very gentle with that other person. The other thing is not abandoning the other person, and I think that is awfully easy to say. We often say, be there. And that sounds so easy. But in fact, what happens is that many of us will be there during the dying process or during the immediate few weeks after death. Stay around with the widow, but then within a few weeks we get bored, or she seems to be doing so well, or he seems to be back in his old way, not realizing that he may still be in shock. And the true reality is beginning to develop months later, and by that time everybody's gone away. Assume that you know, the casseroles aren't needed anymore and the phone calls aren't needed anymore. Human need is not always expressed clearly.
Ladies and gentlemen, if you've joined our program in progress, our guest is Dr. Jane Rabl, holding a doctorate in the field of theology. She is discussing this important topic for 2 weeks with us on death and dying. We shall continue the questioning with panel member Mary Jean Young.
You were talking with Lou about the support systems that families can use or that you can give a family with the dying patient. What advice or help can you give to the medical profession who have to also go through these stages with the dying, and particularly if they are reluctant to let somebody go on to death?
Well, I think you're absolutely right, as you know better than I, since you know the healthcare profession is your profession. But the healthcare team goes through these stages too. I call them part of the constellation of those who are grieving, to a greater or lesser extent. If it's a patient with whom they've invested a great deal or about whom they care deeply, the pain is even greater. And if it's not acceptable in a particular unit in which they work to air those feelings and those concerns and those misgivings or the grief, then it's harder for that nurse, for example, or that resident to deal with it. I think I'm interested that most nurses remember very, very acutely the first time they experienced death on their unit way back. And they will characterize it as having been experienced alone. I think that's without support. And I think that's changed dramatically as we learn that the staff has to learn to support one another, because we do become, in order to be truly helpful, to really be there for a dying patient, means risking feelings ourselves. And some great hospitals have psychiatric help or for the staff. Some great hospitals make time for the staff of the units to get together, like in the oncology unit where cancer is being treated. The whole staff gets together once a week, or the emergency room, to talk about problems that have been difficult, or making the decision on whether to let this person die naturally and whether to terminate. But I think that in that instance, it's primarily the patient's decision. Staff may not always feel comfortable with that, that's true.
Could I ask another question
Yes,
along
of
the
course.
same line? If the family is involved in the grieving process and you're indicating that the professional staff also is going through some emotional response to the stages of dying, when it comes to decision making, then where does the competency come in?
You mean competency to make a decision?
Mm-hmm. If, say, I'm presuming that we're talking about a patient who is in our gray section of not quite competent, not totally incompetent, but sometimes competent and sometimes.
Okay. I'd still say that as long as the person is not legally incompetent, the patient has the right to make the decision, wherever the chips fall. The staff may not like it and the family may not like it, but until that patient is determined legally incompetent, it is the patient's right to make the decision. That's not only a constitutional right, I think that's an ethical right. The Catholic Hospital Association is very clear in it being a moral right that cannot be taken away from the patient. When you get into the incompetent area of incompetency, then that becomes a very iffy thing because a lot of value judgments are involved, a lot of skewed ways of looking at things, and a lot of mixed agendas. And I think that's why, as we said last week, it's really important if the family and the staff cannot agree, and this is a truly incompetent patient, then our only recourse is to go to the courts, as was done with the Karen Quinlan case, as has been done with the Joseph Sakewitz case in Massachusetts, where someone else can, however imperfectly, balance out the interests, but who's not emotionally involved in the situation. I realize the court system may not be the most perfect system, but it gets at least out of that loaded atmosphere which you're describing.
Recently, I've talked to some individuals. They are relatives or friends of a terminally ill individual that is hospitalized. And in fact, one friend of mine explained going to see a young person who was dying, and she felt tremendously concerned about entering the room, and she felt awkward and she did not know what to say. And her experience was that the patient was the one that was comforting to her rather than reverse. However, I have found from these experiences that people are seeking some guidelines to go by or some way of handling what they consider a very awkward situation, especially a friend. Do you have any advice from your professional experiences to aid these people in making that time with the dying person a more worthwhile experience, a more real experience and beneficial?
I think it's rethinking what it means to help. I think that we're a very activist society. We think that helping somebody means doing something for them. We're a very verbal society, and I think we think that there are the words that we can say that somehow are going to make it better. There really, if I'm dying, there is really nothing you can say to me that's going to make the fact of my dying feel better. It's not going to change the reality, and I think as soon as you can say, okay, Jane, say to yourself, Jane, there isn't anything I can do that can change the reality. The least I can do is at least share and be with you during the various kinds of feelings that you have in response to that. Then I think you're going to get yourself off the hook of trying to find the right words or do the right thing. I think most of us get trapped into thinking there's some right words or there's some right thing we can do. And instead, in general, the most it's not true for every patient, the most comfortable guests that a patient can have are those that simply let the patient be whatever it is they need to be. Crying if that's the situation at that particular moment. Making jokes about the future that isn't going to exist for them, in the long term, if that's what seems appropriate. Or being silent and just not being abandoned. I think we have to reconceive what helping means. Sometimes I think it's helpful if families, if they really, our guests are really concerned about a patient who's intubated and has a lot of machinery that's very frightening to them, to go to the nurse's station and say, is what I'm visiting, is there something I should know about, not know about the patient? And they will can tell you things like don't sit on the bed or don't jiggle the bed, or she could use a damp cloth on her forehead once in a while. Just little things like that will be helpful, and nurses are very happy to be able to give you that kind of information.
Thank you. Janelle Burke.
Again, when you discover that you or a loved one is terminally ill, there are certain decisions that you have to make about what kind of medical care. Now, this is presuming, of course, that you're going to have some time to make those decisions, but you're going to have to make some decisions about medical care that is available. Mm-hmm. Do you have any tips about death with dignity or quality of time versus quantity of time, this kind of thing?
How to make that judgment myself if I'm dying?
And some thoughts along how might we think about these things, or how might we think about that with our family?
Well, I do have value judgments because I have my own values, and I will share some of my value judgments about that. But I do think, again, everyone has to find what's comfortable for them. For me, dying in a way that doesn't make me a burden on other people is really important, with some sense of dignity. And that means that I will not want to be prolonged for a long period of time. I will not want life-extending or death-extending. I prefer to call them death-extending technologies when they no longer are prolonging my life but only my death. I don't want those things. I want an opportunity to close my affairs, and so I will demand. I have physicians to talk about the case, the question you asked me last week about how you pick people who are going to help you. I have physicians who are used to telling me the truth and know that I'm going to demand it, because I will want the truth about my prognosis and the options, treatment options, so that I can make some sound decisions. I'm the head of a household, and I have some responsibilities to myself and others. And I think if you're that kind of person, you want that kind of information, and you truly want to make some informed decisions at that time, you want to be able to say goodbye to people important to you and close your affairs, then you're going to have to find staff who are willing to, before you get into the circumstance of dying, staff who are willing to do that for you. The other thing is, I am a very moody person, and lots of people are, and I think I will want to place myself in a situation where people understand that my moods will vary. I will feel confident one moment and feel utterly depressed another moment. And that's true of me now as it would be, I suppose, when I'm dying, and I will need people who understand that.
Are there any ways that deaths of children differ from deaths of adults?
Well, there's a poignancy about the death of children that I don't think a death at any other age can possibly match. The unfulfilled, the promise that didn't reach fulfillment is profound. Especially is that so in a high-risk newborn baby who's done well. All these interventions have been done. The baby's been rushed into an intensive care situation. The baby is responding well, and then suddenly takes a turn for the worse and quite unexpectedly dies. It devastates the family because they had begun to think about taking that child home, had begun to let themselves hope again, and it devastates the staff who's put all this energy into it. And a child who's been among us for some years and has shared a great deal with us is even more difficult. The irony is that I hear families of dying children or children who have died say that they were willing to let the child die, to let the child go sooner than the staff was. And they wished that the staff had been willing to hear that they were really ready to stop intervening. And I also know of many situations in which the child clearly was ready to die, but the parents and the staff were not ready to hear. Which illustrates another thing, which is that everyone has a different internal timetable about how they grieve and how they deal with the reality. Each staff member, each family member, and the patient. And they're not all in sync, which is sometimes why we have the problems we do.
Lou Reed.
How do we minimize the high costs of dying? There are the hospital and the medical costs. There are also the funeral costs, and then there are the costs in terms of human capital. And are there programs going, I think maybe the hospice and the home health care may be one way in which the high cost of medical aid can be minimized. How about the ritual of funerals or any other aspects of these real and dollar costs?
Well, funerals are changing quickly, especially in the Northwest. Is that true? Both in the Canadian Pacific Northwest and the American Pacific Northwest, a lot more movement towards simpler, low-cost funerals. A great movement towards memorial services, which don't involve a great deal of expensive flowers. A lot more movement towards, instead of giving flowers, putting it towards charity. And I think if you look in the obituary column of papers on either side of the border, you'll see more and more of that. I think that looking at the costs of care for long-term care is a really important question. I think it's not only a public policy question, it's also an ethical question. How much money are we willing to expend for whom and for what reason? Why do we give care at one end of the spectrum and we don't provide, for example, we don't provide good nutrition for mothers who are carrying babies who we know are going to be low birth weight because they're so vulnerable. They're living in vulnerable homes. Their mothers are too young. They're not well fed. They may be alcoholic. All these things. It's hard to balance those out. But I think I get nervous when we start talking about costs as the only reason why we should stop giving care, because then I think we border on very dangerous ground. But I think it's an important area that we've got to consider because we have limited resources. So I'd say that economic costs should be a part of the equation, but it shouldn't be the only part of the equation.
Mary Jean Young.
glad we had time, because I thought of a book that I had read, and I think you probably know of some other authors that I don't, but the idea of helping the dying into death by having them experience life after death before actual death. Do you know the authors that I'm talking about?
Are you
They
talking
call
about
it experiences out of the mind, and using
Life
techniques like imagery, and I think there is one school that is using some helping medications in this regard.
I'm only tangentially familiar with them, and I really can't comment too much on them, except that I guess I resist anything that sounds like a panacea, or that's going to work for everybody, because again, we're a very diverse and pluralistic group of people, and what might be helpful for one may not be helpful. I happen to have found for my own self in very difficult situations that self-hypnosis is very, very valuable. And but I can't comment on the things that I'll just let it go at that and say I can't comment.
Janelle Burt.
You are by background a theologian, and do you have tips for the religious person who is dealing with the family or the death of a person?
I think, yes, I think it's one that's particularly of interest to, I think, clergy, but also for families and friends to bear in mind, and that is that especially in any death, there is some residual negative feelings. There's a feeling of guilt, I didn't do enough, or that this death, even though it was a natural death, is somehow my responsibility. And there's a lot of anger. You know, why did you abandon me? Why did you leave me? Or how could you have destroyed my life? And those are negative feelings we don't accept in this society. And we make the griever feel even worse because they're harboring all these negative feelings. I think if we as clergy, as helpers in the healing arts, can be sensitive to those reactions as real and honest reactions, we can help the grieving person move through the grieving process a lot more, not swiftly, but certainly realistically.
I must interrupt. We're out of time. I want to express our appreciation for these 2 weeks. It's been most informative.
Thank you for the opportunity.
Hope you'll be with us again next week, ladies and gentlemen. I am Tony Stewart.
The North Idaho College Public Forum can be seen at the same time each week over this station. This production was videotaped earlier by a North Idaho College student crew for viewing at this more appropriate time.